Everything.
Everything.
It'll be a 7-day conference.
So, what are the advantages of wearing contact glasses or contact lenses over glasses? When you wear glasses, you notice that in the periphery, the edges of the lenses, you get some distortion. With contacts, you don't get that because the lens moves with your eye as you look in different areas. Freedom of vision in terms of if you're really active, you don't have to worry about the frames and glasses moving on your face or losing them. Decreased distortions, we talked about that as well. Some patients just get better vision in contacts because contacts better correct for like their irregular shape of their eye. So some people will always have better vision in their contacts versus glasses. The vision is oftentimes a lot crisper because the power of the lens is closer to the eye than glasses are. And then the range of vision, you can sometimes get more of a range of vision just with the different optics that are available in contact lenses. So a brief history of contact lenses. So way back in the 1500s, Leonardo da Vinci actually illustrated the first concept of contact lenses. And then kind of skipping forward, in the 70s, that's when we first got introduced into soft contact lenses as well as the RGP, the gas permeable contact lenses, those hard lenses. And then in 1981, there was actually approval by the FDA for patients to wear contact lenses overnight, but we'll talk more about that because things have changed a little bit. But then in 1996, we had the introduction of one-day disposable soft lenses, as well as in 2002. So throughout all of history, plastics have made a big role in a lot of technologies, including contact lenses. And contact lenses in general have gotten more breathable on the eye. So a lot of problems with old contact lenses, and sometimes patients think because they failed out of older contact lenses that they still wouldn't do well in contact lenses. But that's a lot of times not true because the materials have gotten so much more breathable and more comfortable in newer lenses and the materials that we have. In 2002, overnight orthokeratology was approved by FDA. Orthokeratology is also known as sleep shaping in our practice. It usually communicates with patients a little bit better about what the lenses entail. And then in 2010, custom manufactured silicone hydrogel lenses became available. And silicone is a very breathable material, but it wasn't always comfortable. It can get a lot of deposits on them that can make the lenses uncomfortable. So the hydrogel was kind of introduced, and it was able to create a breathable and comfortable lens for patients. So that's been important. So there's a range of contact lenses from cosmetic needs in terms of if people want to enhance their eye colors, that's an option, or even theatrical wear. Around Halloween, sometimes we get some requests to have custom lenses made for patients, down to the spectrum of medically necessary lenses where people can't necessarily even function in life without wearing contact lenses. They won't get as good of vision in their glasses as in contact lenses. So those people do have a medical necessity to wear contacts. So there's a lot of different types of contact lenses. The one on the top left is actually a soft custom contact lens. There's also like a hybrid lens, which is where it has the rigid center and a soft skirt to kind of combine the great optics of hard lenses with the comfort of a soft lens in the periphery, scleral lenses, and again, RGP lenses. And contact lenses are used for a wide variety of things. They correct nearsightedness, farsightedness. They correct astigmatism, they correct presbyopia, irregular cornea shapes, because again, if it's a soft lens, it can kind of drape over some of those irregularities, or if the irregularity is so drastic, you can actually use the tears or put fluid in the lens to help correct some of those irregularities. Some patients have actually had trauma to their eyes or were born with their irises being mal-shaped. And so if you can imagine, if you have an iris that's a lot bigger, your eye can't protect itself from light, and so those patients are typically more light sensitive, and so we can actually create custom lenses to help protect their eye from light and diminishing the amount of light that gets into their eyes. And they actually do have some contact lenses for patients that have color deficiencies. It might help them enhance contrast to differentiate between colors. So that's sometimes an option. Soft lens types. So soft lenses come in all different modalities in terms of how often we dispose of the lenses. Daily disposables are the most common type of of soft lens that we prescribe in the office. That's because they are well, actually, I won't give it away. There's a lot of reasons I'll ask you guys about why we want daily disposables on our patients. 2-week lenses are also an option where patients throw them away after 2 weeks. Monthly lenses where they throw them away after a month. And then some custom soft contact lenses patients might not throw away for 3 months and beyond that. In the US, so the most common type of soft contact lens that's prescribed is actually monthly lenses, followed by the 2-week weekly lenses, well, actually the daily disposables, and then the 2-week weekly lenses after that. And then a small percent are wearing them annually. In general, in our office, for soft lenses, again, they're going to be disposing the contacts every day. Scleral lenses, we recommend patients to update them every year, sleep shaping every year. And that's because any lens that you wear more than once in your tears and in the environment, you're just prone to getting deposits, whether it's from the environment or from your own tears, like proteins, lipid, and debris. And over time, those are just building up on the lens, and that adds up over time. That will cause discomfort with wearing the lenses, and so that's why daily disposables have a great option, because you're throwing away any of the dirty debris that's on that. And scleral and sleep shaping lenses, that's why we need them to update them every year, because they are cleaning them, but usually that's still built up over time. Sleep shaping, another interesting thing, they're such small lenses, if you've seen the sleep shaping lenses, that actually rubbing can change the curvatures of the lens a little bit. And for those patients that are wearing sleep shaping lenses, the curvatures are really important in correcting their vision. So that's another reason, beyond just having a better, cleaner lens every year, is also just maintaining the shape of the lens. For the rigid gas permeable lenses, we can use them to correct for spherical prescriptions. There's also toric options, they basically all have different designs to correct for different irregularities like keratoconus or other, if they've had eye surgeries, they might need to have a GP lens over a soft lens. Again, scleral and sleep shaping are also different designs or shapes of the RGPs. So these are the things we don't want to happen when patients wear contact lenses. So some of these are caused by patients abusing lenses in terms of, sleeping in lenses, if they're not cleaning their lenses. Sleeping in any contact lens typically increases your risk of eye infection 6 times. And so even though some contact lenses have been approved to be slept in, you're still more at risk of developing eye infection. So daily disposables, that's a really great benefit, is that patients aren't going to be sleeping in those. But some patients are sensitive to solutions, or if they're using the wrong solution, they can get kind of a chemical reaction on their eye. CLAIR stands for contact lens associated red eye, and so it's not an eye infection necessarily on the bottom right, but they're just having some sort of complication with wearing the lens. GPC stands for giant papillary conjunctivitis. That's that picture in the bottom left. That can happen for a number of reasons, but the biggest one is if they're abusing their lenses and their lens isn't clean and they have a lot of deposits, the friction of their lid blinking over that is going to cause, I almost liken it to like a rash on the inside of the eye. It's really irritated, and the only way you can really stop that from progressing is to usually stop wearing the lenses and probably do some steroid eye drops or kind of anti-allergy drops to help reduce some of that reaction. But as you can imagine, that gets really uncomfortable. So sometimes you'll have patients come in saying, my contacts don't feel as comfortable as they did last year. Well, the contacts are the same, so what maybe happened? Maybe the patient's not using their lenses like they should. So that's why it's important, a lot of our contact lenses, that we look underneath the upper lids to kind of check for that. And again, dirty lenses, like the top left, that's an example of a lens that has some deposits on it. So this is just an example of how prescribing certain types of modalities of contact lenses in terms of it's a daily disposable lens, a 2-week lens, or a monthly lens, how compliant people are. So just because a patient's in a 1-month lens doesn't mean they're replacing it every month. So daily disposables, patients are the most compliant with, meaning 88% of patients that are wearing daily disposables are throwing them away every day like they should. If you notice in more of the extended wear lenses, people tend to abuse those more. And actually the 2-week lenses, Acuvue Oasis is the most common brand for that. That's probably one of the most abused brands by patients. They tend to overwear them and even wear them for a month.
Is there a reason for that, or just?
A lot of times patients, they feel like the lenses still feel good, and so they'll just keep wearing them. Sometimes it's to reduce costs, and sometimes if they feel like it feels okay, that's healthy, but that's not usually the case.
Where they ask patients what's the number one reason, or what are the top reasons, the number one reason that people don't replace their lenses as recommended is because they forget.
Mm-hmm.
So if you start your monthly disposable lens on the 8th of the month, I mean, what's going to remind you on the 8th of next month to replace your lenses?
Yeah.
And that brings up one of the things we like to do in our office, and we don't do it often because we don't do monthly lenses, is if we give a patient a monthly disposable lens and there's only 2 weeks left in the month, tell them to start with a brand new lens on the 1st of the month. And so every 1st of the month they replace their lens. And we have trials to get them by for that 2 weeks or whatever it may be, and we're comfortable giving away those trials. 2 weeks is a little bit more difficult. It's the 1st and the 15th and whatnot, but 50% of people are not doing it like they should. And I mean, you think about it, it is because they forget which day. Cost is always perceived as the number one reason, where really it's just people are not trying to be malicious, they just forget. And their lenses still feel fine, so why would they?
Yeah. Yeah, so there's always important questions that we ask our contact lens patients in terms of, how many lenses you have left can be pretty telling. So if a patient is not ordering a year supply of lenses, but they're coming back in 2 years, so you kind of might want to probe about, how often do you replace your lenses, even in daily disposables. If they're saying they're wearing the lens every day, but they only bought like 6 months supply, then it might, especially for the doctor, kind of tip off, well, I need to maybe look for other things to make sure there's no compliance issues or affecting the health of the eye. We'll always look for that. So a lot of patients have astigmatism. 50% of the population has more than what's 0.75 diopters of cylinder. And the reason that number is important because that's actually the number where contact lenses that are kind of mass manufactured are available in astigmatism correction. So if someone has only half a diopter of astigmatism, that's not available in kind of the ready-made lenses, but we can always make custom prescriptions with any sort of power. It usually comes in half diopter steps, so 0.75, 1.25, 175. But even though patients have astigmatism, a lot of times patients will come and say, oh, I have astigmatism, but it's actually very correctable, and there are contact lens options for them. And so that doesn't preclude them from ever wearing soft contact lenses. Oh. Yeah.
Why sometimes when you're like making the prescription for the contact lenses, if in their glasses they have an astigmatism, but in the contact lenses?
It's different for everyone. Some people, they see pretty well when we don't correct for the astigmatism. There's something called spherical equivalent where we can actually kind of change their prescription a little bit to correct a little bit for the astigmatism power, and that they'll see pretty well. With astigmatism contacts, they can rotate on the eye a little bit, which might just not fully correct their astigmatism, and so for some patients, what their spherical correction versus what they wear in astigmatism contact might be pretty comparable. So you can give that option to patients.
Or if they have half a diopter?
Yeah. If they have less than 0.75, we'll almost always just put them in a spherical equivalent. in the
And if they have
contacts.
0.75, depending on how high their prescription is, we may not correct it. So somebody who has a prescription of -50, -75, the majority of their prescription is astigmatism. So we better correct it. But if you have a prescription of a -9, -75, we could probably give you a -9 and you're gonna see a pretty crisp 20/20 and not really need to correct the astigmatism.
So 40% of the population has astigmatism, and 94% of people with astigmatism have less than 2.25 diopters, which means that we should be able to correct them in contact lenses that are available in trials that we have. Oh, and I should say, even the 6% that are outside that range, there are contact lenses available for them, but like the Biofinity Toric XR, those are ones that we probably have to order in trials for the patient. 80% of patients with astigmatism have what's called axes, so where the orientation of that power is at 90 or 180 degrees, so kind of horizontally or vertically. And so that's why most of our fitting sets, you'll notice there's some common axes that almost all of them carry, usually 90, 180, and around 90, 180 is like 100, 170, 10. And so we won't always have those in between axes because those are just very uncommon. And so the manufacturers don't make a lot of those necessarily because not a lot of the population needs them. Most people fall in those brackets.
So I don't, like, I can never see an axis of like 30 and 40. It just goes like 20, 60.
Yep. And so that's why, like the Biofinity XR stands for extended range. So they make available those in between more rare axes because they know that a lot of the toric ones that are available don't come in those. So that's one that we would order. This is to show how astigmatism correction is different from the spherical corrections. All of the contact lens manufacturers have different designs in terms of how they keep the optics stable on the eye. Even if you had astigmatism in your glasses and if you rotated your glasses, you would notice distortion. And the same thing can happen with contact lenses if they don't orient on the eye like they should. So they do that most commonly by kind of weighting the lens or making it thicker in one part of the lens, and with gravity taking advantage of that to keep the lens rotated and stable on the eye.
And with the blink.
And with the blink, yep.
'Cause people in space can still see.
That's true. On the actual contact lenses, there's little laser markings essentially that we can see underneath the microscope, and you can see with the naked eye if you can use the lens loop too, which is like a little magnifier glass just to look at contact lenses. But we can see these markings, and they're different with different contact lenses, but the doctors know when we look at it how they should be oriented. So if we tell you this lens is rotated 5 degrees to the left or 5 degrees to the right, that's important in the chart. Some patients, even if there's a little bit of rotation, it doesn't affect their vision, but sometimes those small changes in how they fit on the eye have a big impact on the vision. And so there's actually different calculations we can do, or rechecking with lenses over the eyes to see how we're going to order a new contact lens to kind of compensate for how it's fitting. So sometimes you'll see a patient's contact lens prescription looks a lot different, like the axis might be different than their spectacle correction, and that's because maybe the lens doesn't rotate on the eye like it should, so we kind of compensate with that. So sometimes the numbers will look different. Patients might ask that, like, why is this number different? And that's just because it depends how the lenses fit on the eye. But usually it's pretty close to their glasses prescription. Oh, I should say too, I guess it's not related to this slide, but another reason why the contact lens prescription might be different from a glasses prescription. So typically if a prescription's over 4 diopters, as you can imagine, the closer a lens gets to the eye, so with contact lenses, it actually causes the prescription to start to vary because the power varies the higher the power gets. So once you get over 4 diopters, that's typically where you'll start to see a difference. So like my glasses prescription's a -8, but my contact lens prescription may only be like a 750, and that's just because the lens sits closer to my eye, so the power is going to be a little bit reduced.
You can see that if you take your own glasses or somebody near you and pull it further away,
Yeah,
further in.
changes the power. This slide's just to show that there are, even with different astigmatisms, the amount of astigmatisms in terms of how far it extends on the eye. So people might need different corrections or benefit from different contacts, because contacts, just like glasses, kind of have an optic area where the vision's going to be best. And so if you have astigmatism that extends outside of those areas, that you might need to order custom lenses for those people to correct for that. So, a question for you guys. What advantages do you think daily disposable single-use contact lenses might have? Why would we recommend those to patients?
Less infections.
Mhm.
I
Non-text
think it
first.
should be non-text first.
It's cleaner.
Uh-huh.
People remember to dispose of them.
Mm-hmm.
Better compliance.
Mm-hmm. And
Technology's better.
You don't have to have the nasty cases with all the
mm-hmm. That's true too. Yeah. Mm-hmm. Texting them, can you at all?
Most people don't use enough solution to clean them. They won't
Mhm.
actually rub them.
Mm-hmm.
They either won't rub them or they'll rub and then rinse a tiny bit. Or they'll use water.
Mm-hmm.
That happens occasionally, which is super,
Yeah.
super, super bad.
Another thing I like to highlight to patients is the convenience. If you have a patient that travels a lot, it's really cumbersome to bring, those big things of solutions, and so it's kind of nice. They just bring the lenses and kind of grab and go. And if you travel a lot, you might forget, like, oh, this is a monthly lens, when did I start wearing it? Or some people start to confuse, like, well, I've only worn this lens 5 times, but it's a
Right.
30-day lens, meaning you can wear it 30 days, so I can wear it all year if I only wear that lens 30 times. It doesn't quite work like that.
Yeah. So they're good for people who only wear them sometimes.
Hmm. Yeah, and the daily disposables have some of the newer technologies in terms of treatments of the lenses to make them more comfortable, and they take advantage of a lot of the newer materials as well.
They allow more oxygen.
Hmm. Yeah, in general, a lot of the newer designs allow more oxygen to the eye. That's called DK, so if you ever see that sometimes on the packaging, that refers to the oxygen transmission. So there's a lot of these are just daily disposable options that we have for patients. And there's 4 main manufacturers that make contact lenses, and these are some examples of some of the ones they make, and some of those are ones that we prescribe, particularly these ones. So these are our most common single-use daily disposable contact lenses. Fresh Day and My Day are made by Cooper Vision. Bottom right, that one's a daily total one. It's an Alcon lens. AccuView Moist is on the bottom left. Fresh Day has the great advantage. It's kind of our family lens in the office, and that's because it comes also in Fresh Day Toric and multifocal. So if we start patients in Fresh Day, as they age and as they become presbyopic, it's an easy transition because they're kind of used to the comfort of those lenses, so it's kind of easy to transition them into multifocals. Or if someone's on the borderline of we don't know if they need the astigmatism correction in their contacts, we can start off with spherical, but we know there's the option. You don't usually want to fit patients in a different brand in each eye, because the lenses will feel different because they're made with different materials and treatments, and so we always try to keep them kind of in the same family. So for solutions, the average person uses 3 to 6 bottles a year. I might show you an example later. You're supposed to actually, if it's not a daily disposable lens, when you're cleaning the lens, you're supposed to rinse it 5 seconds on each side. And so that usually equates them, they really should be using like 12 to 15 bottles a year, so almost a bottle a month. Oh, yeah. Do you have a lens?
There's a garbage right there. You can just spray it.
Okay, but I don't have a lens.
Well, you don't just do your fake lens.
Okay. So I'll demonstrate real quick how you're supposed to clean a lens. So imagine I have a lens in my hand. You're supposed to squirt for 5 seconds on one side. So this is one side, and then you would flip the lens over, maybe rub it a little bit, and then do
5 seconds. 1, 2, 3, 4, 5.
Yeah. but no one ever cleans their lenses
On
that
each
way.
lens.
Yeah, and that's on each lens. So
both sides.
patients are typically only doing 3 to 6 bottles, using 3 to 6 bottles a year. But if they were really cleaning their lenses like they should in a monthly lens, they would be spending a lot more on solution. And so daily disposables then definitely would be a cheaper option for them because they're not using all that solution. But most patients actually don't clean them like they should, and so they're not spending as much on solution.
So we tell them, they just don't do it.
Yeah.
Can you throw the tissue box back to Heather?
Oh, you need it?
Yes. Thank you. Thank you.
So yeah, patients should be spending up to $400 a year if they're cleaning their lenses like they should, but they're really only spending about $50.
And we bring that up because the number one concern patients have is the cost of daily disposables. That's the biggest argument everybody has is, well, they're gonna cost you more. And so if we accept the fact that they're non-compliant, as a doctor, that's kind of like a dentist saying, well, if you brush your teeth once a week, that's probably okay. So us saying to a patient, well, you don't clean your lenses and you don't throw them away, so that's probably okay. So by us not moving a patient to a daily disposable, and if they're non-compliant, it's us accepting of the fact. So what we want to do is we want to assume that a patient's going to clean the lenses and throw them away the way that they're supposed to. And if they do, we're probably saving them money by going to a daily disposable.
And, I myself, even though I've only been practicing for about a year and a half, when I worked in other offices, the rates of eye infections and complications with contact lenses, which was much higher, and those practices didn't prescribe daily disposable lenses as much. And so I feel like you can make a strong association that they really are the healthier options for patients to be in daily disposables. So daily disposables, pretty much everyone can wear them. Dry eye patients, so like I was saying before, there's dry eye patients that oftentimes say, I can't wear contact lenses, but they may not have tried some of the newer contact lenses that are out there. They specifically now make contact lenses to try to optimize the tear film to keep those patients comfortable. Granted, we're still going to treat the dry eye in those patients because dry eye, again, is a chronic condition and it'll be progressive. So we always want to make sure to treat that as well so they can always wear contact lenses. Allergy patients, those are great people to be in daily disposables because, again, they're getting a fresh lens. So if they were wearing a monthly lens, those allergens are going to build up on the lens and cause more allergies in the patient. Part-time wearers are great. If someone just wants to wear them on the weekend, then they can buy, however many they need for the weekend wear. Kids are great with contact lenses. You never know how kids are going to wash their hands and things like that. So at least they're getting a new lens. All sorts of athletes. Bull sharks, rodeo clowns. These are some of the monthlies that are available on the market. Occasionally, maybe if a patient has a high prescription, like Biofinity is one that comes in higher prescriptions than some of the daily disposables are in. So sometimes there is a necessary need to do those. Acuvue Oasix 2-week lenses we don't prescribe again because typically patients abuse these lenses the most. And contact lens use with age. So there's the blue line is the people wearing contact lenses. So if you notice that as people age, contact lens use goes down, but the need actually goes up. So there's definitely a big unmet need. And again, I bring up the patients that used to wear contact lenses and say they can't wear them anymore. I mean, if you have a patient that comes in that just says they wear glasses, it's always good to ask them, well, are you interested in trying contacts again? Because a lot of times they think that, they're the same old contacts that they used to wear, where actually, again, that there are better designs and new options for them. 83% of patients would like to try contact lenses if they were available to satisfy their individual eye care needs. So again, we should always bring it up as an option for patients, even if they're not wearing them in. Once multifocal contacts were discussed, 75% of contact lens wearers and 60% of spectacle wearers were interested in trying them. So again, even if someone's in a spherical lens or they're not wearing a multifocal or they're wearing their readers over that, if they've never tried multifocals, that could be a good option for them too. One thing that we try to do in the office when we're testing patients' near vision for any presbyopic patients is to kind of give them a more real-world example. So getting away from using the near card for some of these patients and using their phone, because sometimes they can see really badly on the near card and sometimes they see really well, but that doesn't translate to their phone. So realistically, most patients want to see better up close so they can see their phones better. So that's the best real-world thing we can do in our office to test their near vision. And whenever we're first fitting patients in multifocal contacts, the first thing to actually check would be to check their up-close vision with the phone, because that's something, if they haven't been wearing multifocals before, will be the biggest positive experience that they'll have, is kind of that added near vision up close. And then when we test their distance vision, it's usually good to actually start off with a single 20/40 line. Because we want to, have them see that they can still see in the distance, and then we can bring the line down and kind of see where they get on the chart. But we want to just show them that they're having that range of vision with distance and near. So again, we don't want to use the near cards as much for our multifocal patients, using their phone to test their vision. So we always want to make sure to fit the patient, not the prescription. So listen to them with what they need. Some patients, again, might just want to wear them for recreational on the weekend. So they may or may not want a multifocal option because they want really sharp distance optics. So that way they're not running into trees or anything like that. But some patients, maybe they want more correction. They maybe want to see better up close. And we can manipulate the power of the contacts really to optimize whatever they need in their lifestyle.
And I'm pretty proud of us using this statement to describe our contact lens practice, is that we don't want to just focus on the prescription. And even at the front desk, you guys can be helpful in this. If somebody has said, no, I haven't been successful in contact lenses in the past, that doesn't necessarily mean that they will be a failure in our office, because we don't want to focus just on the patient's prescription and fitting them, which is what a lot of other doctors do, is they see the number and they go and get the contact lens that relates to that. Where I think our doctors do a really good job of hearing what the patient says, hearing what's important to the patient, and then we fit the patient based off of what they're telling us, not based on just the numbers.
Mm-hmm. So multifocal contact lenses are much different than progressive glasses and the design of them. And in a similar way, educating patients on how multifocals work is as important as the fitting process, because you want to make sure to give the right expectation. So the advantages of multifocal contacts, they'll have more range of vision. They're not necessarily going to have the 20/20 in the distance, 20/20 up close. That is always our goal, but we don't like to compare it to what their vision is in glasses. The nice thing about multifocal contacts versus doing like a monovision contact, which we're not going to get too much into, but you'll get more depth perception if we correct it that way. And you'll also have decreased dependence on reading glasses. In certain conditions, we still will talk to patients about using reading glasses over the multifocal contacts, but they should have a good kind of day-to-day usable range of vision for up close and far away. Some drawbacks, kind of like I said, they might have more of a soft 20/20 in the distance and up close. Like with progressive, there's an adaptation period. So when we first put on multifocal contact lenses in the office, you don't want to check their vision right away. You want to let the lens settle a little bit. The optics, again, are different. It's usually based off of the pupil size of the patient. So it's really important with contact lenses, especially multifocals, that patients use adequate lighting. So if they're ever reading something up close or a book with their multifocals, if they're not using enough light, their pupil size won't be the right shape to match the optics in the lens. So it's based off of your pupil size. So when you read up close, actually your pupils get smaller, and so it takes advantage of different powers in the lens. So kind of switching gears a little bit to some specialty lenses for contact lenses. So sleep shaping lenses that I alluded to fall in this category. In individuals ages 12 to 54, the prevalence of myopia or nearsightedness has increased 66% between 1970 and 2000. And there are countries, Dr. Dave alluded to, that like in Korea, actually that number is reaching 97%. So meaning everyone's nearsighted, everyone basically needs glasses or contact lens correction to see well in the distance. And so those numbers are increasing quite a bit. And this is a big area of research right now in eye care to figure out why this is happening, as well as maybe preventative strategies to prevent it from progressing. So here's an example that we see in our practice all the time. You'll have a young child come in, maybe an 8-year-old female with this prescription. And when you start looking at their chart, we'll start to notice that their prescription, even though it's just been changing a little bit every year, it is always increasing. And so the mom might say to us, is there anything that we can do so that way she doesn't end up like her dad, who's a minus 450, or maybe both parents are nearsighted? And that's the nice thing about our practice. We employ a lot of strategies, and I think we're really great about even talking earlier, as soon as the patients are even showing like half a diopter of nearsightedness, and if both parents are nearsighted, kind of the odds are starting to stack up against the patient that their prescription is going to keep progressing. There are a lot of different treatment options for what's called myopia control to help slow down the progression of their prescription. Bifocals refer to, is that bifocal glasses, I believe? So where you can actually have like kids wearing like those bifocals where there's a distance prescription and then near. That does help slow a little bit, about 25%, the prescription changes. Some you'll hear all the time where people think that, oh, I don't want to update my glasses to a stronger prescription because that means my eyes are going to keep getting worse, that the glasses are the problem. Well, actually, they've done in studies that if you don't update your glasses every year like you should, and your eye is in this flexible range in terms of it's very sensitive to changes, and that if you're undercorrected, it'll actually make your eyes get worse versus if you wore the correct prescription. So undercorrecting is definitely not a good idea. It'll make your prescription actually get worse than if you actually just wore your normal updated lenses. Atropine is actually a dilating eye drop that you can buy a strong strength, but like any dilating drop, it has a lot of side effects. Patients will be light sensitive. There actually has been found that kids, I can't think of another word other than say they can go a little crazy sometimes when they're on the drops, that they kind of get maybe a little hyperactive or their personality changes a little bit. Was one of the small side effects of this drop. So there is research to investigate maybe doing a very, very diluted like concentration of atropine drops, and you'd put the drops maybe in the patient every day or once a week depending on the concentration. But there have been studies that show that does help slow the prescription. Now they would always still wear some sort of correction where there is glasses or contacts, but that is potentially a way to help slow prescriptions. But as of now, there's no easy way to get the drops. You'd have to have them specially made, and that has a cost with it. Again, and we don't know all the side effects that come from putting drops in the eyes constantly. So that is one that probably in the future will be available for patients more widely. RGP lenses, again, just wearing RGPs doesn't necessarily slow down your prescription, but corneal reshaping, so orthokeratology or sleep shaping lenses have been shown to have one of the best effects in slowing down myopia progression. And then not on here, right, is multifocal contacts are another option. Typically, the doctor usually decides what's the best option for the patients, but if someone has a really high prescription already, but they're progressing, that might be why we do like a soft multifocal over a hard lens.
And just to be comprehensive in this, is there is some there is some binocular vision issues which may draw children to become more nearsighted as well. And so Dr. Shen has also taken the reins on that and has recommended vision therapy for some of those patients if they have one of those issues as being the primary cause of why they progress in their nearsightedness. So we try to take a all-encompassing approach to slowing the progression for kids.
So why does this happen? Well, anatomically, if we're wearing normal correction in terms of glasses or contacts on our eye, when it creates an image for our eye and our brain to see, if you notice, this image is kind of a straight line. And so what happens is that you get this image that in the periphery of the eye that is not matching up with the back of the eye. So essentially in the periphery of the eye, it's actually getting a little bit of blurry vision. Now most people don't sense that because we're looking with our macula, but what happens is that kind of instigates the eye to maybe grow longer to meet, that blurry part of the eye. It wants to meet the image, and so that causes the eye to want to become
To our
more
discussion
nearsighted.
On Tuesday, those images in the periphery are falling behind the retina. So is that hyperopic or myopic if it's behind the eye? Who thinks myopic? Who thinks hyperopic?
Yes. So a myopic person, the image would be in front of the eye.
And they'd have not a convex lens, but, or, I'm confused, what's convex? Is this convex? Because this is concave?
Correct.
Okay, the lens in front
The
of the
lens in front of the eye. So, and the ideal system for correcting prescriptions would be to actually get that image cell to match the shape of the back of the eye better. And the way we can take advantage of the cornea, because there is flexibility in terms of gently reshaping it with wearing a lens at night, to change how the image comes into the eye. And so we can actually alter that image shape, that image shell, as we like to call it, so that way it matches the back of the eye better. And so on the sides of the cornea, more in the periphery, it's a little steeper, and we can what we can take advantage of in reshaping the eye is making the periphery of the cornea a little steeper and flattening the center to create an image that matches the back of the eye. So essentially, this is a little exaggerated. When patients wear sleep shaping lenses, it actually just reshapes the cornea by the thinness of a piece of hair, if not thinner. So it's microscopically changing the shape of the eye. We use our topography to show us how it's reshaping it, because you can't tell just from looking at the eye that it's making the right shape. But again, it steepens up the periphery of the cornea as well as flattening the center to create an image that matches the back of the eye better. And so what we want to see on the topography is that picture on the left. Blue, again, means flat, and so we want to see a central flattening on the eye. And again, and then you see like a red ring on the maps when we do that.
In that map, just to give you an idea, if you've never looked at a topography, the image on the top left, that circle, is what the eye looks like before we do sleep shaping on the eye. When the patient comes back, we do a topography again to see what change to the shape of the eye has occurred, which is what the bottom left picture is. And then the right-hand picture is a subtraction map. So it's taking the top minus the bottom, and it's giving us the difference. And so we're able to see that there's a significant flattening, and that's what the blue is of the eye.
So as you can imagine, a lot of parents can have questions about how these things work, and so that's why we do offer a myopia consultation for patients, so they can have dedicated doctor time to explain how this works. Because even if they were to look it up online, it can be a little bit confusing. So it's kind of nice to be able to show patients and explain to them one-on-one the different options and how undercorrecting. A lot of times they've asked around and heard of other options, so we can kind of troubleshoot and answer questions directly.
And is that a charged visit, and how long is that visit?
Yeah, the myopia consultation, we charge $100. I think it's a 30-minute visit. Usually at that visit, we try to take topographies because that'll educate the doctor in terms of what options they might have, and also to know, have expectations of maybe how many visits, because depending on their eye shape, more complex eyes or more complex personality, sometimes it's the parent's personality that might mean we need a little bit more visits to, kind of explain to the patients as we're going and encourage them that we're getting the right results. But yeah, so that's $100 that can be applied to if they go forward with sleep shaping correction or with myopia control options that will be applied to that later. But sometimes patients come in knowing, yeah, I've already researched it and I want to do it. And so if we have time in the schedule, then sometimes we'll squeeze that in and go ahead and do the fitting at the consultation as well. But that's usually up to the doctor.
And we generally do not do or plan to do the fitting.
Correct, yeah.
As stated, and the reason why is because parents don't always know the cost. A lot of people know that it costs quite a bit more than a pair of glasses, but not everybody does. And so when they come in, we spend a half hour with them and we're ready, and let's assume that we always fit everybody at that visit and they're ready to go. But then we tell them how much it costs and then they're like, nope, never mind, I don't want any part of this. So the $100 that we charge is kind of to educate them, to share with them what it's all about. But if somebody was to call in and say, I want to schedule a sleep shaping fitting, I'm ready to move forward, I want to do this, then we would still schedule them as a consultation, but whoever's talking to them on the phone can just say, great, I'll let the doctor know, and then record a note that says the patient wants to move forward with the fitting, is very eager or something. That way we move along the process a little bit longer and try to get through their questions faster.
And we most commonly do sleep shaping for kids, but they actually were originally approved just to correct for nearsightedness. So the FDA approval for the lenses is almost like an alternative for LASIK. So adults, we have patients that either have heard about it and they want to be fit into it because maybe they have dry eye and they know that LASIK can kind of cause dry eye to be worse, so they're not a good candidate because they have dry eye. So this is a great alternative for adults to correct for their nearsightedness. We can even do a little bit of monovision, so under correcting one of their eyes, and they don't have to wear contacts. So some people just don't like wearing contacts for whatever reason, and this gives them a great option as well. So we try not to forget about that and recommend them to patients if they have kind of a low amount of nearsightedness. That's pretty easy to correct. Does anyone have questions on myopia control or sleep shaping? Jackie?
When patients put on sleep shaping lenses,
Mm-hmm.
are they just like Plano because it's the action of the?
So the
consultation,
actual
or are they
the sleep shaping lenses that we use have a little bit of power in it, but that's actually not, the power itself isn't to correct the patient. It's
It's
the
like sleep
shape.
shaping,
It's the shape of the lens that essentially helps correct their prescription.
I was
Am I
curious
saying that right?
If they
You are,
get
but
up
the
to go to the
patients can see
bathroom.
20/20.
They can see 20/20
generally
with the lens.
on.
Yeah.
Oh, okay, so
So
like.
it does
they-
correct their prescription, but
Yeah.
if they can't see in the lenses, that does not indicate that they won't see once the correction's done.
Correct. Yes.
What's how hard is it / like what is the range of what you could do sleep shaping on for astigmatism?
Yeah, there's not necessarily, there are limits. The most successful patients are typically under 4, but we've corrected people under 6 diopters, even patients with astigmatism. There's been research, though, even if we don't fully correct the nearsightedness or we don't fully correct the astigmatism correction, that they still get the positive effects. They still get the slowing down of myopia progression, even if they're not fully corrected. So in some patients, even if they have a high prescription, they'll wear sleep shaping during the day, and then we'll prescribe them a low-powered glasses, because what happens is, as you can imagine, the higher your prescription, if we reshape the eye generally, because you're not wearing the lens during the day, starts to go back to its normal shape a little bit, and the higher your prescription, maybe the faster that happens over the course of the day. So we'll prescribe some very low powered glasses in case, the kids late at night want to watch a movie or something like that, and they might have a little residual correction at the end of the night, so they can wear glasses for that. Or we can do contacts sometimes for that residual correction. It kind of depends on how old the patient is and what they need them for. But yeah, so there's not necessarily limits.
Okay, this might be kind of a stupid question, but so you can have progressive myopia.
Mhm.
Can you have an astigmatism that gets worse every year without having keratoconus, and could something like this
Mhm.
help with
Mhm.
that?
Yeah, sometimes you can't, some patients don't always accept their full astigmatism correction, and sometimes as you age, your eyes accept it more. So there's different reasons for that. If you're an eye rubber sometimes, or there's different reasons that you can change the shape of your eye and change the prescription.
So eye rubbing can lead to astigmatism, is what you're saying?
Keratoconus is the biggest thing we worry about that it can instigate, possible. But just because you have high astigmatism and keeps getting higher doesn't necessarily mean you have keratoconus either. Yep.
We charge 2 different fees for sleep shaping. We charge, the lower rate is generally if somebody has a prescription that's 4 or less, or I should say less than 4. Or if they have a mild amount of astigmatism. And we use 2 different types of lenses in our office. We do use a more expensive lens if somebody needs their astigmatism corrected at higher amounts. Or if they have a higher prescription, we charge them the higher amount.
Mm-hmm.
We kind of make we don't necessarily just lay that out for every patient that if you have this prescription, it's this. Because we as doctors in the room like to look at the shape of the eye, the prescription of the eye, the behavior of the parent, and that helps us decide how much we're going to charge.
Yeah, no, because certain parents, there's always kind of a range, right, of 20/20, and so sometimes patients or parents, want us to keep tweaking things, but it's important to kind of reassure the patients and show them sometimes we don't always show these maps to patients, but sometimes we will for the parents so they can understand that we're getting the treatment that we want. Just to add to that too, the kid's personality matters too, because if it's all based off of there's an extra cost if it's a complex fitting because we expect to do more visits with the patient. And so sometimes that's because it's difficult for the patient to even get used to wearing the lenses, so we know it's going to take more visits.
How long do people usually use sleep shaping for?
We think it's great if they use them even their whole lifetime in terms of because you can correct your prescription even as an adult. Even if your prescription's not changing, you can wear these lenses. And we do have some patients that started wearing them as a kid and they liked the convenience of them so much that they kept wearing them. The biggest time for change in a kid's prescription is kind of around the ages of 8 to 12. So I try to tell parents it's good to try to commit at least to that time frame, but every year, and that's why we see them at 6 months as well, to kind of take a gauge of how much it's helping slow their prescription. Because obviously if it still is increasing a little bit with doing this, that it's even more important to stay in it if it's still having a little bit of progression. But they can do it their whole life.
So if they do it every year, it's still like the 2,200 each time?
No, so that's a good question. So that's just for the initial fitting because it does take a lot of time to get to that right lens. But typically after that, every year we just have to do little tweaks. And so we only need like a visit or two sometimes with those patients, and so I think it's $225 for the annual sleep shaping evaluation is the coding for that.
Okay.
So at their annual, and we can usually do that at the annual eye exam. So we'll check their eye health, we'll double check their residual prescription, and then we can make tweaks usually to their lenses, and we'll just charge the annual evaluation charge. But they do pay for new lenses again because they do need a new set of lenses every year because of
So about like
how rubbing.
usually.
Yeah, that's right. Because I think the lenses are $400 each. Yep.
And if somebody, the purpose of the annual agreement is that somebody comes in annually.
Mhm.
So the whole purpose is that because we can charge a lower cost, we don't have to do a whole lot on the patient.
Mhm.
But if a patient doesn't come back to see us for 4 years, we may have to kind of start all over.
Mhm.
So then it may be more expensive
Mhm.
because we kind of have to start from scratch.
And a lot of this information is on that sleep shaping form, so you're always welcome to read that. It's at the front desk. Another thing that we offer for patients, and I really always encourage it for anytime we're doing a new fitting, is for patients to do the warranty, because as you can imagine, kids, or anytime you're first learning to use a contact lens, you're not handling it maybe the way that you know you should be. They're kind of learning that, and so that kind of gives them a warranty in terms of if they break the lens, if it falls on the ground and they step on it, that they're covered for that, they don't have to pay for the full cost of the lens again. So I always like to recommend that, especially the first year, because some parents will ask, well, do you think I should do it? I always recommend it for the first year, and if they take really good care of their lens and they don't have any breakage that first year, then maybe the next year they don't need to.
How much is the warranty?
It's 200.
And then if they break a lens, it's 200 to replace it?
So the full price of the lens is 400. So if it covers them for one breakage on each eye, so if they broke a lens on the right eye twice, they would actually have to pay the second time for the full price of
So
the
if
lens.
they get the warranty, which is 200, and they break a lens, then they get a replacement for free, or they're
Mhm.
paying $200?
Nope. Well, they've already paid the $200 at usually the fitting, or when they picked up the lenses. But yeah, so that's already been covered up front. We just note in the chart that they've used up their right lens warranty. Any other questions on sleep shaving before we move to
And our
sclerals?
warranty is set to be so that people can be comfortable using it if they need to. And we also have our warranty set up so that it's easy to have us taking advantage of. The patient does not have to present the lens and show that it's broken. We put our warranty that if you lose the lens, break the lens, whatever happens to it, you can get a new lens for free. So somebody could come in a day before their year visit, pay the $225 for an annual supply or an annual agreement, and say, I broke my lenses. And, we don't want to be taken advantage of in that way, but we would technically be able to say, okay, well, if you lost your lenses, then you get a new pair for free.
So let me go back. They can actually pay for the warranty.
At the time of the visit, they have to buy
Okay,
it
at
at the
the time
beginning.
of the visit. Okay, thank you.
Yeah, not when they've actually broken.
Not when
the
they
lens.
do.
Yeah.
I wanted to, yeah.
But they can buy it the second year. If they didn't buy it the first year and
Oh,
they're
yeah.
kicking themselves, then they can buy it the next time they buy new lenses.
Yep.
Okay.
Thank you.
So scleral lenses, and everyone will have the opportunity later today to put a scleral lens on and help each other put one on. But scleral lenses have actually been around for a really long time, but probably just in the last decade, because the materials have gotten better and our understanding of how these fit on the eye have gotten so much better that we've gotten them to be really comfortable on patients who really need them. So when we order these lenses, there's a lot of ways we can customize the lenses so that they fit an eye appropriately. Again, a lot of times we're putting these on eyes that have very unique shapes to the or shapes just to the cornea of the patient. Sometimes they have unique personalities too, but there's different areas that we can adjust and customize for the patient to get it to fit as well as we want. So there's the central optic zone. That's where a lot of the power of the lens is. The limbal transition zone is essentially just a transition from the central optics to get us comfortable, what's called scleral landing zone. So these are called scleral lenses because they don't rest on the eye. They actually have the weight of the lens rests on the white part of the eye, the scleral. Actually, technically the conjunctiva on top of the sclera, but that's why they get their name scleral lenses. So someone that might need to wear scleral lens or get the best vision from a scleral lens is radial keratotomy. Has everyone heard of radial keratotomy? So RK actually was developed around the same time LASIK was, and what it entailed was the surgeon using a scalpel essentially and making these cuts just directly on the cornea. It wasn't guided by a machine, they were really just freehand cutting these. And the amount of cuts depended on their prescription. So the idea was that, again, remember the nearsighted eye is usually a longer eye. So if they made these cuts in the cornea, that it would flatten their cornea to essentially create an eye shape that would correct itself better. But as you can imagine, if anytime you're freehand doing anything, you don't necessarily have control on doing the same amount of depth or length of these cuts every time. And so, there's every time we see an RK patient, almost every patient looks different. Some patients, I don't know, Dr. Dave, what's the most you've seen? I mean, I think I've seen like 30 or 40 on a patient, 30 cuts.
72.
72, yeah.
And there's a picture of the guy right
And patients, so this is, yeah, someone with 72. So what's interesting is patients actually had really great vision, usually for a decade or two after they've had this, but it's kind of over time where there wasn't much control over what kept happening to the eye. So a lot of times they just kept getting flatter over time, and then eventually they didn't have that clarity of vision that they originally had. So that's why a lot of times we'll see patients later in their lives after they've had RK where they aren't getting great vision anymore, and so we need to come up with other
They
options.
don't get very good vision because their cornea keeps getting flatter and
Mhm.
flatter and flatter, and they keep getting what prescription pills. They get higher and higher prescriptions. They become more myopic or hyperopic. The power of the eye keeps getting weaker and
Keeps,
weaker
yeah,
and weaker.
eyes getting shorter. What do shorter eyes usually? Yeah.
Yeah.
So people get these surgeries to correct their nearsightedness, and later in life they end up becoming really hyperopic.
I had a patient that had it done and she went from a -8 and she had great vision for about
Mhm.
5 to 7 years, and then she started getting more and more plus to where the last time I had seen her she was a +8.
Mhm.
So
Mhm.
she says I would have never had it done if
Mhm.
she knew what would have happened.
So, on a patient like that who has 72,
Mhm.
is that like the surgeon just went haywire in one trip, or he
Sometimes,
kept going
not
back?
necessarily. Yeah, sometimes when they don't get the results they want the first time, they'll go back and they would do more cuts. There are also like T cuts that they sometimes go back in, where they, instead of doing the lines, they'll make a T on the line to try to change the correction a little bit. So we'll see that too on patients. And sometimes these patients will report when they come into our office that their vision's blurrier at the beginning of the day than the end of the day, and that's because their cornea is essentially compromised, the shape has changed. And so at night is actually, it's normal for our eyes to swell a little bit, but because their cornea's kind of been altered, that their eyes will swell more than the normal eye, and so their vision will be a little bit blurrier in the morning sometimes.
So a lot of people still have this done today?
So it's not actually done anymore that I know of. Maybe in other countries, but yeah, I haven't seen it.
It was
around.
very popular in the 80s
Mhm.
and early 90s, and so we still see a lot of patients who have had it
Yeah.
done.
But usually not any
And,
new.
The
cases,
use of
yeah.
glasses is not great for them in general because their eye shape is so distorted.
Mhm.
And also, as Dr. Young stated, their prescription is variable, and so they need something that maintains the shape of their eye throughout the day, even if their eye shape changes. So that's where a custom contact lens comes in, because
Mhm.
the front surface of the contact lens doesn't change its shape. So if the eyeball behind it changes, the contact lens compensates for that.
So this is how a regular patient with RK might, their eye might look. And so, they're really steep in some areas, flat in some areas. But as you can imagine, having a contact lens, like a soft contact lens, to match all of that can be pretty difficult. There are some patients that with RK can wear contact lenses. It kind of depends on how extreme the changes of RK have been. But a lot of times scleral lenses will give them the best vision because it kind of can smooth out and kind of correct all these irregularities using fluid in the lens and the tear film. So this is showing a scleral lens being made, I believe. So they use all of this really high-tech equipment, and they use what's called a button. So the material is made in these little button-looking like plastic discs, and then they put the information of the prescription and the shape of the lens into a computer, and then kind of press play, and then within a few minutes these lenses get made. And they usually use diamond tips that have to get changed out sometimes multiple times a day, that kind of grind in the prescription and the power in the lens.
Making a video.
So they start out pretty much is flat discs, and so they're kind of grinding in the curvatures and things like that on here.
Could take the tag, first tag off of them. Are we gonna return it?
Hopefully Pat doesn't use this audio.
This is actually a soft, custom soft contact lens.
Oh, it's a soft one. Both of them?
The bottom one, you can see that we're making the front surface of the lens. You can see that there's a vertical, and the top one is making the back surface of the lens. So all custom soft lenses start off as hard lenses, and then they come to it.
So here's an example of a custom soft lens. Alden Optical is the name of the lab. So there's labs across the country, and they all usually make their own proprietary design, so very unique to their lab, to correct for different eye conditions and different eye shapes. So you know, just because one soft specialty lens doesn't work on a patient, there are sometimes other options for them as well.
And we use Valley for all of our contact lenses, but Valley doesn't do custom soft lenses. That's why we're here.
Is Valley the one that's done in Renton?
No, they're in
Springfield, Oregon. Yeah.
There's one right down in Renton.
Yeah, there is one or two that are in Washington. Mhm. So, does this look like a normal eye?
Totally.
What do you think this patient experiences? What's probably their primary complaint?
Too much light.
Exactly. So the iris is kind of a natural, it's something natural in the eye that helps protect our eye against light, the inside of our eye. And someone that has either had eye trauma or born with an iris that is unable to do that is going to be really light sensitive because there's too much light coming into their eye. And so that just makes them really uncomfortable typically. But with the option of custom contact lenses, we can actually create kind of artificial irises or just help block out light that comes into the eye.
Is that a lens that was in the back? Like he had like an
Oh, yep.
implant?
So he had, I think it has a anterior segment IOL. So I think you can kind of see the edges right here. And it's,
He
yeah.
needed cataract surgery, but they couldn't put it into place because it wouldn't stay in the bag that is in the posterior chamber. So he has an anterior chamber intraocular lens.
Yeah, probably one of the most common reasons patients when they get cataract surgery can't have a normal implant is if they've had like trauma that's cut like what keeps the lens capsule in place, or the lens capsule is damaged, and so they just essentially put the implant at the front of the eye. So it's underneath the cornea, and it'll be like usually affixed to the iris.
Yeah, so these patients cannot be dilated.
If you did, what would happen?
Oh, God.
But you usually don't need to because they have big irises, yeah.
This is one of our patients, actually. His
Uh-huh.
name is Robin, and he found us because he needed a contact lens. And he had, about 25 years ago, got a piece of metal in his eye and just decided to keep itching it.
Oh.
And as he was itching, he was just tearing his eye to shreds, and he tore through his cornea and through his iris and ripped the lens in his eye all up, and decided to stop itching when blood and water was flowing down his cheek.
So in a custom contact lens, we can almost create an artificial iris to help block out a lot of that light to keep him more comfortable, and then also put prescription in the lens so that way we can correct his whatever prescription that he has.
What could he see through that?
He was, I believe, I think he was like 2050, 2060 when he came in, but with that lens, we were able to get him, I think, to 2025.
That's amazing. I can't believe he could even see.
Yeah, with any sort of trauma, it kind of depends also if whatever trauma affected the retina too. If their retina is intact,
Right.
a lot of times we know the
Then we can still
potential.
see.
Yeah, regardless of how irregular the front of their eye, if the retina is healthy, we can get them
And no
usually
scarring.
20/20. Exactly.
Did he have scar?
No, his cornea was in pretty good shape.
And in office, we can even tint lenses again for patients that are light sensitive are probably the most common reason that we'll do this for patients. And we can make a lot of different colors. We have blue, all the colors that are shown there, but usually kind of browns or dark colors are the most common to help block light for patients. And we'll do this with soft lenses.
Can you use a color